Hello, and thank you for joining our program, COVID-19 and Multiple Sclerosis, an MS TeamWorks Forum. Before we begin, I'd like to go over just a few introductory remarks. This program has been developed by the Consortium of Multiple Sclerosis Centers and Catamount Medical Education. We would like to thank EMD Serono for their generous support, which helped make this program possible. Throughout the panel discussion, we encourage you to ask questions using the Ask a Question button on the left-hand side of the screen to submit questions pertaining to COVID-19 and MS. The panel will do their best to answer as many questions as possible during the question and answer session at the end of the program. Also on the left-hand side of the screen, please visit the survey button. We value your input for future programs, so if you haven't already, please take a moment at the end of the program to complete the survey. Today on our panel, we have Ms. Denise Bruin, who is a neuroscience nurse practitioner and clinical director of operations at the UVA MS Clinic in Charlottesville, Virginia. Michelle Wansley, a patient of Ms. Bruin's who has been living with relapsing remitting MS for 18 years. Dr. Shin, who is a professor in the Department of Neurology at MedStar Georgetown University Hospital in Washington, D.C., and Lindsay Turner, a patient of Dr. Shin's who has been living with relapsing remitting MS for 4 years. We hope you will find this program informative and lively, offering guidance on MS and COVID-19 and how to best coordinate care through the use of telemedicine. I'd like to turn it over to Dr. Shin.
All right, thank you. Let me get control over here. So we've got sort of a lot on our plate today. All right, so our first slide here, we're going to obviously be talking about COVID-19 and its interaction with MS. This is a really hot topic because obviously this has really changed the world in terms of the way the pandemic's affected people all over the planet. But then the intersection of MS is obviously what's brought us here today for this broadcast. So what do we know about the interaction of COVID-19 and MS? Well, the one thing I kind of want to start out in terms of reassuring the listeners is so far, it doesn't look like MS itself increases risk from COVID-19 as far as we can tell. So evidence from the experience of our colleagues in Europe, as well as so far the past several months where we've been struggling with COVID-19 here in the US, has not suggested that our MS patients are at greater risk from COVID-19 in general. Having said that, we do have to recognize that there are some populations of individuals who might be at greater risk from COVID-19 than other members of the population. I think for people watching this currently, you're aware that we've recognized certain subtypes of individuals have to be extra cautious. So some of the things that we're paying attention to is older age. So this has just been observed globally that our individuals who are in an older age group seem to be more susceptible to COVID-19. This is true for actually a lot of viruses. So even every year we have seasonal flu, and we know that our older patients or very young patients are more vulnerable to infection from these viruses, and COVID-19 seems to be similar. In fact, as some of you may know the statistics, in terms of very bad outcomes or even death due to COVID-19, it's overwhelmingly our patients who are in an older age group that have been suffering that risk. Now, when we think about our patients with MS, they come really in sort of a whole range. As you know, children, young adults, middle-aged, older patients, all can have multiple sclerosis. So we obviously have patients who have MS and fall into that older category where we are going to have to be extra careful. But there are other things to keep in mind. So for example, having multiple sclerosis doesn't automatically prevent you from having other conditions. So the other things that we've recognized that carry risk include other kinds of health issues, whether it's lung disease, heart disease, diabetes. These pre-existing conditions we've also recognized can increase the risk of COVID-19. This includes things like obesity. It also includes things like immobility. And this definitely intersects with MS in that MS patients can have advanced disability, and that or being in a nursing home, for example, could put you at greater risk from this infection. Now, what to do about this. So there's a question, which is, even if we reassure our patients that overall MS doesn't seem to increase the risk from COVID-19, how can we be sensitive to patients with these additional risk factors? Maybe I'll call in my colleague, Denise. I don't know if you wanted to comment at all, or I think we've all observed the same demographic issues, but I don't know if that sort of changed how you practice in terms of caring for your MS patients.
I think when everything first hit, if I had a patient that was in a wheelchair or lived at a facility, I really try to minimize them coming into our facility, trying to make it a virtual appointment if we were able to. I think as we've learned over the past couple months, though, some of those risk factors have kind of changed in terms of what we know with older patients, and not just looking at kind of the condition of each patient, or like we'll talk about soon, the disease modifying therapy that somebody's on.
Yeah, well, actually, that's great, because that brings us right over to our next slide, because a natural question that's been coming up in our clinic visits is, well, even if, let's say, having MS may not directly be a risk factor for COVID-19, what about the medicines that we're using to treat people with multiple sclerosis? And again, I guess I would emphasize, we don't know, or there doesn't seem to be any evidence that being on any particular MS medication increases the risk from COVID-19. There are a lot of discussions, I would say, in our world where immunologists are discussing potential reasons why patients might be more at risk. But then, to be honest, there's also conversation about maybe why certain treatments for MS might, in some sense, be helpful, from preventing too much inflammation. Overall, I would say we don't have evidence to say that it is good or bad. I would say it sort of washes out. What you can see on this slide is something that's been put out by the National MS Society, trying to categorize our MS medications into groups that might be considered higher or lower risk. I'm going to editorialize a little bit and say that we don't have evidence that the medicines in fact fall into these categories. In other words, we don't have evidence that certain drugs are safer and then other drugs are riskier. The truth is, thankfully, so far, it doesn't look like any of our patients have had issues, but you can see the categories. So we do recognize that some of the medicines that have been used to treat MS tend to have a really good safety profile. Ones especially that we've used, let's say from the 1990s, have never really been associated with much in the way of infection risk. And so it was thought, well, maybe those would maybe be safer. On the other hand, we do have a category of medicines, and again, I'm going to editorialize and say some of our most effective medicines act by clearing out or reducing the number of certain types of white blood cells. And so, hypothetically speaking, people had been concerned that in doing so, to help our patients with MS, could we be exposing them to greater risk? And then there are a number of medications in the middle, which I would say may or may not significantly reduce white blood cell count, but perhaps in the studies have been associated with an increased risk of certain kinds of viral infections, like let's say herpes type infections, for example. And so one might wonder whether there's a greater risk. So I have to say that I felt like we should be honest and say we don't exactly know. And I personally haven't recommended stopping or halting treatment of MS, because what I do know is not treating MS is a problem. But Denise, so how have things been down at UVA?
I would agree with that. I think, again, given a patient's other factors, age, or the type of MS, both of our patients today have relapsing MS. But for some of our more progressive patients, if they're older and have other comorbidities, I did delay their treatment by a month or so until we knew more. I had a Lumtrata patient that was due in April. I also delayed her treatment because we just didn't know. And until we knew more, it just felt safer to wait. And we'll go into that a little bit more about why we might recommend that for some of our patients, changing the timing of mainly infusion therapies.
Yeah, I think that's definitely been sort of the area where there's been the most, I guess, maybe concern or question in terms of what's the best way to approach this. I think some of the treatment options give us some flexibility, right? I think that with some of our medications, we do have the luxury of maybe waiting for finite period of time to see how the situation evolves without, I think, feeling like we're putting them at extra risk. I think one of the challenges, though, is that the reality is that we may not be able to detect small differences in risk, good or bad, just because this pandemic is so new. And the number of patients that have been collected in our databases, despite our best efforts, is, if we're honest about it, relatively small. Well, as you said, we'll touch on this a little bit more later. Well, the last slide that I was going to kind of cover is in terms of our treatment recommendations. Denise and I think, have already talked about this a little bit, which is that it's a balance. Certainly, I think it's realistic that in this time, this really unprecedented time of concerns about this viral infection, resulting in dramatic changes in society in terms of social distancing, wearing masks, shutting down our businesses, closing, our hospitals in some regards. I could see why obviously people are going to be concerned. However, at least my feeling, and I think hopefully Denise would share this, we have to balance this with our responsibility to continue to control multiple sclerosis. I can, go into social isolation, but MS isn't taking a holiday. MS is still affecting my patients with MS, and so we do have to manage this. My balance has been, for the most part, to try to stay the course, to make sure that my patients continue to get the treatments that they need, and also to reassure my patients that we're tracking it closely. But again, thankfully, so far, so good. So I'm going to turn it over to Denise in terms of any more thoughts on that issue, and then turn the slides over to you as well.
Great. Thank you. Okay, I just have to move this box here. So I think you're right. I think, there's certain things that we can forego. Graduations, birthday parties, that kind of thing, but we can't say when somebody might be having a relapse or might have a pseudo relapse because of if they do have an infection. Luckily for us down here in Charlottesville, we've had not as many COVID infections as we thought we would, which I think is a good thing. I think social isolation has really helped minimize that, but I have had some patients develop the infection and actually succumb to it, unfortunately. Trying to forward my slide here. There we go. So like I said, patients can still have relapses or have need for steroids during a pandemic, and we can't just stop that because, as Dr. Shin said, the outcomes of that are bad. They can be catastrophic to patients. So we have to kind of look at different ways of evaluating a patient if they need steroids. So doing FaceTime, or we've been doing a lot of video calls with patients, which we'll talk about a little bit later. And also just what is the risk of giving steroids during the pandemic? Steroids do suppress the immune system, but I actually saw a study today looking at COVID in steroids, and if patients have lung issues involved with COVID, actually giving steroids seemed to be helpful in terms of outcomes of those patients. But as most MS patients know, we use steroids all the time. So it is safe, so we think, to give a short course of steroids if needed. So that can either be Solumedrol or ACTH of Acthar. Acthar can be very expensive and difficult to get to patients, but the beauty of it is that patients can administer it at home. We've actually been giving more of oral corticosteroids, which is taking a whole bunch of prednisone pills. So that is another way really to avoid patients having to go into the infusion center and deal with other people. And then also screening for symptoms of COVID before doing this treatment. So a fever, if they have any signs and symptoms that they might be infected or have been exposed. And I do think that most healthcare facilities are screening patients in their caregivers, because that's another risk factor there, before even letting them into the building. So if we think that a patient has a confirmed or suspected COVID-19 infection, this could actually cause a true relapse. More importantly, it might cause what we call a pseudo relapse or temporary worsening of their symptoms. So sometimes patients might actually feel their MS before they have the actual lung infection and other symptoms that would bring them either to the hospital or to their primary care doctor. As Bob would probably agree, a lot of our patients turn to us first. We know many of our patients for a very long time, so they often trust us and contact us for a lot of different things. So we need to be aware of this as well, to let them know where to go, where to get testing in your community, that kind of thing. So this is hot off the press. So this is the Italian cases because they're a couple months ahead of us with the COVID infection. So they kept a database, a registry of patients with MS that developed COVID. And what they found was 232 patients from 38 centers in Italy developed COVID. Most of them were not actually tested because I think when this first rash of the pandemic happened, there wasn't testing. But most of the people, 96%, had a very mild case of COVID. On the right-hand side is the COVIMS registry, which is for Canada and the US. And this was started, I think maybe starting in March is when we started trying to collect this data. So as of today, there's been 288 patients reported in North America with MS with COVID. 94% confirmed that they have MS. They might have some other demyelinating disease that we take care of kind of under the umbrella of MS. 81% of these patients were positive for COVID. Again, there's a lot more testing than there was when Italy first had their wave. And what we're seeing is that really the statistics, the outcome, the mortality is about the same as in patients that don't have MS that are affected with COVID. So that's about 5.6% mortality. Some of it we don't know, just because it's all based on providers reporting this information, and sometimes people just don't follow up, or somebody else is taking care of the patient, and maybe the neurologist doesn't know kind of what happened to the patient once they realized that they were infected. So the main thing that we're really trying to do is how to keep our patients safe. When this all first started, as Dr. Shin said, we were really concerned that our patients having MS, which is an autoimmune disease, being on immunosuppressant therapies, that our patients just might have a really hard time or might be at higher risk for developing COVID, being exposed to it, or just how they might recover from it. So we know a little bit more now that some of these medications don't seem to, they might actually be kind of beneficial to some of our patients, but we still want to keep our patients safe. So ways we've tried to do that is home delivery of medications. Most people have a specialty pharmacy that they don't have to go to the pharmacy to get their symptomatic medications or their disease modifying therapy. It can just be delivered to their home. We've been trying to delay MRIs if they're not really needed. We often get an MRI on patients yearly just to make sure things are stable. But if a patient's feeling okay, we're trying to, again, delay that. I know at our center, from what patients are telling me, that it's like they're in and out of there. Same thing with blood work. They have an appointment, they are called in, the staff calls the patient at their car out in the parking lot or parking garage and lets the patient come in right when their time is done, and they get in and they get out. So that makes patients feel really comfortable, as well as taking their temperature, also limiting who their care partners are coming in with them. If the patient does not need help transitioning or communicating, then they are asking family members or friends to stay in the car and just have the patient come in. We've also done some less frequent dosing of infusion therapies. These cannot be done at home as of right now, although I know some of these companies are trying to get home access for them. But natalizumab, which is usually given every 4 weeks, we've had some patients that we've given it every 6 weeks. We know that it doesn't leave the system before 6 weeks. There's actually testing being done of extended dosing. So again, it's just trying to minimize how often patients have to go into the infusion suite and be exposed to others. Same thing with ocrelizumab. This is a medication that's approved for relapsing MS as well as progressive MS. So again, for some of my progressive patients that might be older and have more of those risk factors, we have delayed treatment a couple months, just again to keep them out of the infusion center, as well as trying to minimize how much we're suppressing their immune system if they were exposed. And then lastly, what is kind of the crux of this whole discussion is telemedicine. At UVA, we had a small telemedicine division up until about March 13th. And then it just kind of exploded. So everybody's doing telemedicine now. There's a couple of different platforms. We can't do it as Zoom like we're doing this presentation today because this is not a secure platform to be talking about patient information, but there are different platforms out there. There's pros and cons about it that we're going to talk about. It's nice that for a lot of our patients, they don't have to go anywhere and they can still get the needed medical care that they need. One of the downsides, though, is doing the whole exam. I tried in the beginning to do that with patients. It's just really difficult to try and capture that through the camera. Where I am in the middle of the state, we have a lot of rural patients, and some of them, they just don't have really good internet access, if at all. So we have to kind of decide what's the biggest thing that we need to address in their appointment, which is making sure that they feel safe, that they know the latest information, and that they have their medications, and also who to reach out to if they do need something. Okay, so with that being said, I think we're going to bring out our patient guest here. So I'd like to introduce Michelle Walmsley, who is a patient of mine here at UVA. And then we have Dr. Shin's patient, Lindsay Turner. Okay, I have a different screen here. Okay, hi guys.
Hello.
Hi.
Hello.
Okay, so what I wanted to start with asking you, so Dr. Shin and I invited you guys here today because over the past couple months, we have had a telemedicine video with you and just kind of hearing your experience about that. So can you tell me I'll start with Michelle since you're my patient, just to give us a brief synopsis about your background and, kind of where you're at with your living with MS.
Sure. I've actually been relatively stable and feeling healthy the last few years. In fact, the last time, Denise, that I saw you was on a telemedicine visit because shortly before the pandemic, I began having symptoms that we weren't sure if they were an actual relapse or a pseudo relapse. So I had a visit to you actually, I think the week before schools shut down here and my employer moved to remote work. So our telemedicine visit at that point was really an essential part of our MS care because you and I were having a conversation at that point about our MRI follow-up, what we were going to do in terms of next step for therapies, and also addressing something that at that time was a fairly big concern for both of us, which was that some test results had come back that indicated that my white count was really low. So telemedicine felt really essential to me in terms of protecting my own health and safety and not having to come into the university hospital setting.
Mm-hmm. Great, yeah. And Dr. Shin and Lindsay, how about you guys?
Yeah, maybe I should introduce my patient, Lindsay, and I'm just going to comment that actually in my practice, like yours, we've shifted almost completely over to virtual visits, mostly out of concerns about minimizing infection risk. But I would say I found it very positive. I don't want to bias my patient in any way, but just because in a way we've been able to be more responsive to our patients. In fact, my volume's actually up. I'm actually seeing more patients because we can set up the virtual visits in a way more rapidly. As you said, examining patients is a challenge, but a lot of, I think, what we do in MS is address concerns, work through lab results. We have the ability to look at MRI scans. So the platform we use as at your institution, we don't use Zoom, but we have a sort of a more secure platform where we can mirror the screen so I can show them the MRI images and work them through. So it's actually been kind of a positive. And you also touched on the fact we all serve patients who may live very far from our clinics, or I do have some patients that are fairly disabled, and so travel can be quite difficult. And so this has really opened up a new opportunity. I'm sure in the future we won't be 100% virtual, but I hope that we maintain a good percentage of virtual visits. But I did want to introduce my patient, Lindsay, and maybe you could tell us a little bit about your MS experience as well.
Yes, thank you, Dr. Shin. So prior to COVID, I have not had to use telemedicine, but as Dr. Shin said, I live a far distance, it was very convenient. I had questions about COVID as an MS patient. You know, it's concerning, it's worrisome, and I we talked about that, and then we talked about medications. As my husband and I are beginning to start a family, this is important to my health and my MS. So we talked about my current medication, future, and intermittent. He reassured me to continue to do what I'm doing as far as the COVID precautions, and I let him know that I was doing well and staying active during the quarantine.
Maybe I should ask you, and I don't know what your answer is going to be, but when you compare coming to visit me in person versus doing a virtual visit, do you feel that one's better than another? Are they about the same? Advantages, disadvantages? What do you think?
It is always a pleasure seeing you in person, but I have to say it was very convenient to call in and not have to drive about 2 hours. So it was convenient, but and we still got to have the same conversation as we would in office. So I think it was a very helpful, very positive outcome.
Great.
How about you, Michelle?
I would say so too. And I think one of the nice things for us was that we were able to follow up really quickly on some emerging test results. And also at the beginning, as Denise, you and Dr. Shin have both mentioned, is that we didn't know what we didn't know. So being able to have a thought partner walk you through all of life situations. What happens in return to work? What happens in this situation? Am I safe doing this? Is it okay if I'm in this setting? You know, and just having someone to talk through those types of situations that are important for any of us to think about during COVID, but especially for someone who's dealing with MS, and especially for someone who's having some of the challenges and potentially an exacerbation, a relapse, or just dealing with some of the other comorbidities that you mentioned.
Yeah, I agree. So you've been working from home, Michelle.
I have.
That other things that you've been doing to kind of reduce your risk of infection?
I have been. I've been really fortunate to work from home since about mid-March. I've not gone into a grocery store, so I've been getting grocery delivery. That's been a real bonus. Curbside pickup for necessary items, really minimizing any need to be inside, limiting the number of people who are close contacts, practicing really, I think my kids would probably tell you, pretty extreme social distancing and encouraging them to do the same. Of course, wearing a mask when that's not as possible as I wish it were out in public, and being really careful. The other thing I've been doing, and you and I talked a lot about this too, was staying active, making sure that even though we can't go to gyms, is that staying fit and using the online fitness classes and apps. I still have my running partner, and we really maintain quite the distance, practically across the street. But that helps, and all of those things I think help keep us healthy, which can certainly be a good buffer and is good for our MS anyway.
Yeah, kind of the silver lining, right?
Yeah.
That now you probably have time, because you commute quite a distance for work, and now you have time more so for your girls and exercise.
Yeah, absolutely.
And Lindsay, what about you? Have you been, I don't know if you work outside the home or if you've been.
Yes.
Mm-hmm.
Yes, so I have been teleworking since the beginning of March, so it does have its pros and cons. You said the commute, and I will echo off Michelle's comments. I do grocery pickup. I haven't been out in public since March. Once I do get my groceries, I bring them home, wipe them down, disinfect everything that I possibly can, and also make sure that I exercise every day in some type of form, and to balance, a healthy diet, and just to continue wash my hands and social distancing. I do not get close to anybody, and ensure that they know, look, just keep your distance, and I'd like to remain healthy.
Right. Lindsay, have you had to have any blood work or MRIs throughout any of this?
I have been very lucky. I have not had to have an MRI. As MS patients, we like to have them, maybe once a year, just to ensure that everything is as it should be. So I'm, would love to have an MRI, just follow up, hopefully once all the corona, settles down some. I'm not in a serious rush, as I have had no symptoms of a relapse. So, and that would be something that I would just follow up with Dr. Shin. So definitely do that as a follow-up.
Okay. And Michelle, I know you've had to have blood work and MRIs. How was that for you going into a facility?
I did. You know, it was interesting because I had my MRI on the 15th of March. So shortly after, Denise, as you know, many things shut down here in Charlottesville. So I was the only person in the facility, in and out early, very quickly. A few weeks later, actually, we postponed my blood work. I think my follow-up blood work even a little bit. And again, too, temperature checks, a lot of making sure, you know, cleaning hands, cleaning doorknobs, cleaning all, you know, folks are really being very careful about it. Masks. I felt very safe. So I do think that when it's necessary, it feels like it can be done quickly and sort of expeditiously. So
great. Okay, and have you guys spoken with any other MS patients about their experience during this? Some people are very private with their diagnosis and don't know, you know, other people's living with MS, and some people are part of support groups. So have you heard from any other folks living with MS and their experience with this?
I actually am a member of the MS Society. So I have been on there and read a lot of articles, and they have forums. So I've been on that a little bit as far as COVID, and I've done a lot of research before I talked to Dr. Shen, because the unknown is very concerning about COVID and MS. So I have had that. And of course, my family and friends have been very supportive. But as far as like a one-on-one interaction, I have not had that with an MS patient during this pandemic. So that would be something great to have. And if anybody needs that, feel free to reach out and we can talk to each other.
Any tips you would have for somebody that's doing telemedicine for the first time?
I would say make sure that your space is quiet, well lit, and it will be a face-to-face, which is nice. You can see, so make sure that your background is sound. And I will say I did have a great experience with telemedicine. One tip that I would like to note is that the link to the invite for the appointment was sent to me about a minute before the call. So I thought Dr. Shin was going to think that I didn't attend the meeting and that I missed it. So I just want to let everyone know that if you're, you know, if you get the invitation late, don't think that, you know, you're not getting it at all. It's there. So it will come to you like right as the meeting is starting.
And I think that depends on what institution you're at. You know, we have Epic, and so it's usually sent through MyChart, but some patients don't check their MyChart, or if they log in, we use DoxyMe a lot. If they log in through MyChart, the 10 minutes, like it says beforehand, it logs you out of MyChart 30 minutes in. So that then loses it. So a lot of it is just kind of a learning experience on our side too. And I agree, like I can see sometimes patients are there in my waiting room, or I know they're not a patient that's going to miss an appointment. So usually we'll call or try to make it work if somebody, you know, doesn't show up. So, but that's good. I wouldn't stress it too much.
Yes.
Well, but that's good feedback, because I think you're exactly right. As we have different platforms, in a way, we should do a better job of letting our patients know what to expect. You know, it's kind of a brave new world. And we're used to things like Zoom, where, you know, you would set the appointment, you know, weeks ahead of time, and then you know that it's coming up and you know what to click. Whereas, as Lindsay just revealed, our platform sends live links that expire. So basically, we send them at the time of the appointment. But I do think you're not alone. I've had other patients who are like, "Oh, I was so nervous because like I didn't hear from anyone. I didn't know what was going to happen." So it's a great example of how we need to do in this new time. We have to do a good job of explaining, you know, what exactly is going to be happening.
Yeah.
And then for me too, I would say as a patient, if you're treating this the way you treat an office visit, another great way to think about this is also to make sure that if you've got questions or concerns, that you write them down, because especially if you have any hiccups, I know Denise and I had some at the very beginning of ours. And I think we may have had to reconnect during ours. That happens sometimes, whether your internet is slow or someone gets kicked off and has to jump back on. Just writing your questions down so you can get back on and sort of not miss a beat and get distracted or sort of thrown off by that is helpful.
I would say another thing is, just like in the office, like I have a 10 o'clock, a 10:30, 11 o'clock. So if somebody's having a lot of trouble logging on to their appointment and they're like, "Oh, I'm here, you know, 30 minutes late," like I'm sorry, but I have another patient schedule. We're going to have to reschedule. Luckily, it's pretty easy to do virtually, but there is still a similar kind of time crunch, just like when we're in the office seeing patients. Is that what you found too, Bob?
Well, I was just thinking that I realized I should have been a better physician when I was doing things in person, because I used to do things like overbook slots, or
Oh.
maybe it would run late, and then I'd say, well, I'm sorry, I'm running late, I'll catch up with you. And I think that the nature of telemedicine means that at 10 o'clock, I have to be with this patient, and then at 10:30, as you said, boom, I have to be, I can't do something like run 20 minutes, 30 minutes. Like, that's just not fair. And to be honest, it never was fair. So now I'm realizing, it's like, oh, I
Really?
haven't been a good doctor. I need to do better. So it's forcing me to be more disciplined about making sure that I'm doing what I need to do on time, and in an efficient way. So
Yeah. Yeah.
that's actually a positive.
Yeah. Well, good. Good. All right. Any other thoughts that anybody wants to share about their experience with telehealth or tips for other patients?
I wonder if we could dive into some of the questions that that our audience has been sending in. And I was thinking, actually, the first question fits in just to what you're sort of leading us through this discussion, because one of the questions that was typed in is, do you think that home infusions and telehealth would become the new norm? So I don't know. What do you think? You kind of touched on it a little bit. You mentioned that it's moving in that direction, but what do you think?
Yeah. So I think telehealth, I think, is here to stay. As Lindsay said, it saved her a lot of time having to come in, park, all of that. So I think for patients that are stable or that I've known for a while, I would feel comfortable maybe having them do telemedicine for 50 to 75% of their visits, depending on how often I see them a year. I do think it's important to see each other face to face, to do the exam, to kind of lay hands on, because there's so much information I get just even from when I first walk in the room, reading the patient and how they're dressed, how they're sitting, a lot of different things. You get some of that too, seeing patients in their own environment. But I do think that there is something different being seen in the office. So I do think in a way that's here to stay. The biggest issue with home infusions is some of these medications have a REMS program, so a monitoring program, because of potential for side effects. So depending on how long someone's been on a medication, that may or may not be okay. The biggest issue we have, again, in our area is just home health nursing. And having manpower. And it's still somebody coming in your house too, which some patients aren't comfortable with for different reasons. So there might be somewhat of an uptick with that. I think it'll be interesting to see disease modifying therapies moving forward, though, in what becomes more preferred just from a patient aspect, in terms of what patients can either inject themselves or ingest themselves and not have to go out and do that.
Yeah, I think that's actually a very important insight. I think we were already trying to move towards home infusion when possible, but I think the crisis really brought maybe more momentum there. But as you just pointed out, there are also problems intrinsic in the idea of home infusion. A individual healthcare provider moving from, let's say, one home to another home, this potentially could really contribute to the problem we're trying to avoid in the first place. And then, as you said, do we have the resources for that? Another issue I think that comes up from a telemedicine standpoint would be, maybe this is too nitty gritty, but reimbursement. One of the reasons why telemedicine didn't really take off in the past is because there was not really a good mechanism to bill for that. There wasn't really a program in place that would basically compensate providers for doing telemedicine. And in the crisis, because of the emergency, I don't know if everybody in the audience is aware of this, but telehealth visits are being reimbursed at the same rate as in-person visits, and this is part of the explosion of it. But I think, Dennis, you would agree, it's unlikely that it will remain that way when the crisis resolves. So, but in a way, the genie's out of the bottle. I think some of the advantages there are hard to ignore, and so we probably can't go back all the way.
I wonder what Michelle and Lindsay think. Now that you've done telemedicine, what are your thoughts about being seen back in the clinic?
I think Denise, I was thinking about that when you were saying that you can tell so much just by your initial interaction with someone. I know we've had some of those visits where I'm sure just being able to have that first interaction and impression, you can sort of get that sense. The advantage that telehealth, though, seems to have to me over trying to do some of that by phone or trying to puzzle some things out by email is that we at least have the sort of visual cues of being able to, it's one thing for you to say, that's risky in an email. It's another thing for you to say, that's risky in telehealth. So that's how it's certainly not in person, but it's a much better substitute than some of the other ways we might have to communicate about more mundane things that don't require a neurological exam.
Sure.
Actually, that's one of the other questions, that came up. Lindsay, maybe you can answer this. Like, how do you feel about just dovetailing on this? How do you feel about telemedicine? And we've had a nice interaction. I don't know. What do you think in the future? What would your preference be?
I agree with Michelle as far as, it is convenient for those office visits that, don't need the exam. And for people like myself who commute to see, their doctor, it is convenient. But probably like a percentage where you could do the telemedicine calls and then, per the doctor, come in and we'll do a physical exam, or if the patient feels that they only want to do. So I guess it's really just an understanding between the patient and the doctor of what is best for their care.
Yeah.
Here's another question, again, sort of along the same line. Denise, maybe I'll ask you. One of the comments or question was that one of the benefits of a live visit is to address family concerns or patient concerns about worsening. Could telehealth ever fill that gap? What do you think?
Yeah, I think so. I think I get so much from my patient's spouse or caregiver in terms of what's going on at home that, patients will come and say, oh yeah, everything's fine. And you can see their spouse look at them like, what are you talking about? Or they're like, oh, they're lying about it. So it's kind of a time for the caregiver to address their concerns. And also, caregiver burnout as well, like what's going on at home. I think, again, it's interesting to have a video appointment with somebody in their own home to kind of see what their home looks like, whatever they show you behind them, or kind of get a sense of what goes on at home in terms of patient safety and that kind of thing. So I think telehealth could help with that. I think, though, that oftentimes, I think more for the caregivers, it's a time that they feel that they can also be heard. And I don't know how that would work with telehealth, because for us in being just compliant with HIPAA, confidentiality, but also billing, like I can't have an appointment with somebody's spouse to talk about what's going on. But if they come into the clinic with them, we can separate a little bit and talk. So
that's a great point. Yeah, because a lot of the times when we're doing telemedicine, what I've noticed is the patient will get in frame, but then their partner or spouse is off frame, and sometimes they'll hear mumble like, and then they'll bring up something else. But as you said, it's different in the office where you can really read both the patient and their friend or family member and get a lot of information that way.
And sometimes also, who's around you right now on telehealth, because there might be something that the patient disclosed to me that could be helpful to them if I said it and, somebody in their family heard it.
Yeah.
So that's a bit more difficult to read as well.
Yeah, there's actually a very, another, I guess, telemedicine challenge. Somebody asked this question of, since we have individuals who may not be able to manipulate technology without assistance, what kind of either educational support or equipment would be needed to basically effectively do telemedicine when someone has a lot of disability? That's a great question.
It could actually open a lot of doors, because there is a lot of assistive technology out there for patients that might not be able to use their hands or only head controls. So in some ways, it might actually open up to things they didn't realize that they could be using everyday life, to read a book or to move their wheelchair, or Alexis to turn on the phone, that kind of thing. And I've had some telehealth visits with patients that are bedbound, and so I did not want them coming into the clinic. But I also just didn't want to talk to them on the phone either, because again, having that face-to-face is so important. So their spouse was able to, get it on the iPad and put it where they could see it, and then, left the room so they could have some privacy. So I do think there are ways that even with manipulating equipment that it can be done with a little bit of assistance from somebody else.
Yeah, I think that's a great point. I'll be honest, whoever asked that question, thank you for asking it, because I hadn't actually thought about it. But, we traditionally did things like if somebody needed assistance with driving, we would go out of our way to get adaptive equipment or hand controls. And I do neuroophthalmology, and when patients have visual issues, we would make sure they got to a low vision therapist and got different kinds of accommodations, whether binoculars or telescopes. And, I realize I should make sure that we're doing this for this new world as well, that make sure that we can get them the kind of equipment that would be necessary to allow them to take advantage of telehealth. So I actually thank whoever entered that question. That's you made me think about that. That's great.
Well, I also see a question on here about mental health services being reimbursed with telehealth. Some of this might just be state by state or different insurance providers, but I've heard a patient I saw on video actually told me that they've been seeing a therapist since March through telehealth, and that it's really helped them deal with the isolation as well as anxiety that's just come out of this whole pandemic.
Yeah, that's a great point. And I think even before this crisis, that was a little bit of an option, counseling or therapy, but it already was such a challenge in the MS world. We've talked about in other forums how the majority of MS patients will experience some degree of anxiety and depression. And yet, to be honest, we're not great at providing support or mental health care. And so maybe, again, another silver lining of the crisis is if we can have more access to mental health resources, and that our patients could take advantage of it. So I think that actually would be huge. I see a number of kind of technical questions that are interesting, and at least two of them have to do with vaccines. So again, we don't have a COVID-19 vaccine yet, although people are working on it, and we've heard different things about when one might be available. I think the most optimistic projections were that if we were really lucky by the end of the year. But I think we have to be realistic and say we may be stuck dealing with COVID-19 without a vaccine into maybe 2021. But when a vaccine becomes available, it sounds like people have already begun to question, will our MS therapies affect that? So two of the questions, one was just thoughts on taking routine vaccines at this time during the crisis, but then a more technical question about specifically certain types of medications. Let's say a medication that depletes B cells. Would that have impact in terms of responding to the vaccine or affecting the timing of how we would do that? Any thoughts on that?
So in terms of the B cell depleting therapies that can last a while, I've definitely have pause of starting patients on that therapy through all this because of thinking forward when a vaccine is available and what that would look like. Because this, we do this kind of dance, right? About like when somebody gets infused or when they take their medication, what are the rules with the vaccine pre and post? So, these are things that in neurology we have to think about that you wouldn't have to. So I think I'm not sure what that's going to look like. I think it'll be interesting when a vaccine is available, what we know about the vaccine, the safety, the efficacy, that kind of thing. So I think that's still a story to be told that I can't really say for sure what I'm going to do.
It is difficult. And I think, Lindsay, Michelle, you've lived with it in terms of having MS, and, maybe every year things come up like the flu vaccine, or, should we get it or not get it? And there are differences, right? There's some vaccines where if you're lucky, you take it once and that's it, you're immune. But as we just mentioned, the flu doesn't work that way because the flu virus keeps changing, and we don't really know what this coronavirus is going to do. So that's one issue, is maybe we'll have to keep asking ourselves, or have to deal with vaccination. The one thing that I've kind of mentioned to some of my patients is, let's say, especially B cell depletion, which this question focused on is keeping in mind that we've used B-cell depleters for probably 20 years or more, not just in MS off-label, but in many other rheumatologic conditions. And thus far, although we do know things like it might affect the antibody titers that we see later, people do still seem to be able to mount immunity despite treatments of really any of our MS medications. Certainly I think, as Denise brought up, we'd have to be thoughtful in terms of timing, but I guess I try to reassure my patients, I think it'll be fine. Like, I think, first we have to get the vaccine,
Right.
but once we do, I think that all of our MS patients will be able to benefit from it. And again, when we know more, I think we'll fine tune this a little bit for sure.
Yeah.
So,
I agree. I would have a little bit of hesitation because the vaccine would be so new. But if it is to prevent, it is definitely something to talk about. Being that as an MS patient, your immune system could be lower. So it definitely could be a positive, but definitely a lot of thought and knowledge and research will go into it.
Yeah.
absolutely.
There's one question I can see here, Dr. Shin, I want to address. Somebody asked why their neurologist might not offer a telemedicine visit. So a couple of thoughts there. One, maybe they're not set up to do it. I mean, it could be as simple as that. I know at our institution, we can only do telehealth with patients in the state of Virginia. The patient has to be in Virginia. And some of that has to do with liability, with the way our malpractice insurance is set up. So depending on where you live and where your provider is, that could be an issue why they didn't offer it to you.
Yeah, and I do have to say, I do know colleagues who, I think you and I have talked about how we've done a lot of virtual visits, but I do know colleagues who have seen basically all of their patients are still face-to-face. However, I do believe that they are taking really CDC recommended precautions in terms of distancing, meaning not packing the waiting rooms full of individuals, maybe not even having waiting rooms. Just like we do curbside pickup, we can do, come up when it's clear to do so. Obviously, they're using good hygiene in terms of hand washing and wearing of masks and cleaning the rooms and the equipment. And so I think we're all doing the best we can. I do like telemedicine, but we have heard there's some there are pros and cons. And so there isn't really a right way to deal with it. I was going to actually make a general comment. There was a number of questions that are very technical in terms of related to very specific treatments, maybe that someone's on. Somebody asked, actually, does COVID increase risk to MS patients? We kind of covered earlier. I did want to make the general observation that so far it does not look like MS patients in general are more at risk from COVID-19. And I'm going to say that also for specific medications, whether we're talking about B-cell depleters we touched on, a class of drugs that target S1P, that's a number of different pills, Gilenya, Mayzents, and newer medicines as well. Zeposia is also in that class, where they can do things like we know they'll affect the lymphocytes, but regardless of these specific issues, and I hope you agree with this, Denise, so far, thankfully, it does not look like any particular class of medicine it predisposes patients to a greater risk from COVID-19. So I just would like to at least reassure the audience of that as much as possible. Yeah.
And they've actually looked at some of these treatments for treating some of these MS treatments, for actually doing some clinical trials, looking at them and treating COVID because of the immune response that happens.
Well, you brought
trials though, but yeah.
Yeah. Well, you brought up a great point, and somebody had asked this or asked if we were going to comment on the research you just mentioned, the finding of corticosteroid, dexamethasone, seeming to be very useful. And it's kind of complicated, but it's important to remember that getting the virus, COVID-19, that's one concern. But the other concern that really leads to the very severe breathing difficulties is excessive inflammation. And, what do MS treatments typically work on doing is suppress that inflammation. And so maybe, as you mentioned earlier, we were worried about infection risk with corticosteroids, but what seems to be discovered is, but there's a benefit in reducing the deadly inflammation that can occur. So again, maybe somewhat of a positive in that regard. So let's see, we have a couple other questions. I think there's a question about pregnancy and a vaccine. I'm just going to say, like, I guess it'll sort of depend on the vaccine a little bit, right? And so
Yeah.
we don't know. I can't really say too much about that right now. Comorbidities, mentioning rheumatoid arthritis as an example, but I think we did touch on the fact that there are, even though I just said I don't think MS increases risk for COVID-19, there are other conditions that we touched on, diabetes, obesity, heart disease, lung disease, or diseases that are truly immunosuppressant. So MS is an immune system disease, but sometimes I say it's not, your immune system isn't too weak. If anything, it's a little bit too strong. It kind of overreacts sometimes. But it's true. If you have MS and another condition that puts you at risk, obviously, we'd have to take extra care.
Yeah. But in terms of RA, I don't know if we know those two to get like enough details. Again, we only have 280 patients with MS with COVID in North America. So having MS in RA, I don't know. And I don't know if they have a registry as well.
Yeah, that's a great question. And also, I think it would depend on sort of how the rheumatoid arthritis is being treated, because they're different treatments. So I'm sorry, we probably can't get too specific. There's one question I kind of delayed answering this because I wasn't even sure how I was going to answer this, but exercise in public swimming pools, does it increase the risk of getting coronavirus or for patients on treatment?
So a lot of pools, again, depending on what state you are and what phase, a lot of pools have not opened for the summer. Our pools here in Charlottesville, you can rent a lane for just your family for an hour. So really it's not, to me, so much like the water, because if it's properly treated with chlorine, it should kill that off. It's really how many people are hanging out on the pool deck, how many people are close at hand with you. In some ways, exercising in a pool might be cleaner because you're outside and everything should be chlorinated than like in a gym. And a lot of our patients love exercising in the pool because you can't fall. You can do a lot more movement and stuff. So I really think it depends on the hygiene factors of that particular pool.
I think you're exactly right, as you just pointed out. If anything, the chlorinated water, its whole purpose is to kill virus and bacteria. That's why our eyes burn when we're in the swimming pool because of the excessive chlorine. But you're exactly right. I think it's really the social distancing. It's, the locker room or standing by poolside or sitting in by the side of the pool. Like, those are areas we still need to be careful. And it's kind of hard to wear masks, when you're in the pool. So I think that's the issue. All right. I don't know, Lindsay, Michelle, did you have any other last comment? We're kind of winding down. Time has flown by, but I wanted to give you guys a chance. I think, any last comments?
I think telemedicine's been a great option. I think, as we all talked about, it's not the only, but there are so many situations, and perhaps that's part of the key. It's situational. There are so many situations in which it is effective, both in normal healthcare situations and also certainly in a case like the pandemic.
All right, Lindsay, last words?
Sure. I will agree with Michelle. It has been great. It's easy to access. And for a tip, don't panic because your link will be sent to you. And just stay active during the quarantine and stay positive. I know, we might be able to get down on ourselves in quarantine, and just stay careful. Continue to, wear your mask and just wash your hands and social distance.
All right. So Denise, did you want to have any last comments before I wrap it up?
I think this was a really good discussion. I've learned, hearing from the patients and from you, Dr. Shin, just your experience on both sides of the fence there. Again, I think it's here to stay. I think there's ways that we can make it improved on both ends, and, we'll continue learning.
All right. Well, we're down to the last minute. I just wanted to summarize and say even though there's a lot we don't know, I would say, as you've heard, there are a lot of positives in that so far patients with MS seem to be doing well. We all need to continue to be cautious, as all of us in our community need to be, but there's certainly, hopefully, light at the end of the tunnel. And I think we're certainly learning a lot from this crisis, including things like how to maybe take care of our patients in a better and more efficient way and iron those kinks out. So hopefully you can see on the slide, there are a number of resources for patients living with MS in terms of COVID-19 resources that you can access, including some of the information that Denise presented earlier. I do want to thank MS TeamWorks, as well as CMSC and Catamount Health for putting this program together. I want to thank Lindsay and Michelle for being willing to join us in this podcast and to become TV stars. So that's really, I really appreciate it. And most of all, my colleague, Denise Bruin. It's so fun to work with you virtually. And thank you for making me take off the baseball cap so everyone could see my face. All right.
Thank you for having me. It's been
awesome.
a pleasure.
All right. Good night, everyone.
Good night.